Good afternoon, everyone. This is Christine Friedenreich speaking. I'm the Interim Scientific Director for the O'Brien Institute for Public Health. And today you are joining us for the next version of Anatomy of a Pandemic, how COVID-19 is impacting children's health and social well-being. Before we begin, I would like to give a territorial acknowledgement. I would like to take this opportunity to acknowledge the traditional territories of the people of Treaty 7 in Southern Alberta. The City of Calgary is also home to the Métis Nation of Alberta Region 3. The Anatomy of Pandemic series was started by the O'Brien Institute leadership at the beginning of the COVID pandemic, and it's essentially an opportunity for us to share with the broader University of Calgary community and all of our outside members some of the work that's being done by us here at the O'Brien Institute, as well as at the University of Calgary, particularly to help support authorities and governments in their response to this unprecedented scale of human cost exacted by COVID-19. As I mentioned, I'm going to be moderating this series as your interim scientific director. The recording of this and past webinars are available on the O'Brien Institute website. Today's speakers are Drs. Jim Kellner and Dr. Deinera Exner-Cortens. Dr. Jim Kellner is a professor in the departments of Pediatrics, Community Health Sciences, and Microbiology, Immunology, and Infectious Diseases at the University of Calgary. He's a pediatrician and a subspecialist in pediatric infectious diseases and a clinical epidemiologist. From 2008 to 2018, he was professor and head of the Department of Pediatrics at the University of Calgary and the Calgary Zone of Alberta Health Services. His research interests are in the field of vaccine-preventable infections, and he works with colleagues from clinical medicine, public health, and basic sciences locally, across Canada, and internationally. He will be joined by Dr. Deinera Exner-Cortens. She's an assistant professor in the Department of Psychology in the Faculty of Arts, and also an adjunct assistant professor in the Faculty of Social Work, and she's jointly appointed to the Department of Psychiatry in the Cummings School of Medicine at the University of Calgary. She holds a PhD in developmental psychology from Cornell University and a Master's of Public Health from Boston University. Dr. Exner-Cortens' research focuses on child and youth health promotion. In her work, she collaborates with a number of community and research partners, both provincially and nationally. So now I'll be handing it over to Dr. Jim Kellner, who I can say I've had the great pleasure of working together with on the COVID-19 University of Calgary Advisory Task Force. So I look forward to his presentation and that of Dr. Deinera Exner-Cortens. And before I end, I just want to say that we will be having an opportunity to have questions and answers to our seminar speakers. And so how to do that is just to essentially use the Q&A box in Zoom, and you can also send us your questions via Twitter at the handle that's provided there, and we will try to answer as many questions as we can during this particular digital forum. If we don't have the opportunity to answer all the questions, we will try to answer them after the forum. So we look forward to a lively discussion with our speakers, and thank you for joining us.
Thank you very much, Dr. Friedenreich, and I'm pleased to be here today. I will be speaking very briefly, and so if I'm speaking very quickly, I apologize in advance. For the portion of the presentation that I'm making, these are the two key objectives in the outline. First, to review the usual and uncommon but notable clinical features of COVID-19 in children, and then to compare and contrast rates of infection, transmission, and disease in children and adults. I've given a few presentations on COVID-19, and each time I usually make the disclaimer to say, well, we'll talk about the numbers and the disease, but we won't talk at all about the really major impact on the health and well-being of children. So I'm really pleased today to take part in this presentation, where that'll be a significant part of the presentation by Dr. Exner-Cortens. So first, a bunch of numbers. What I want to do is just sort of give people a sense of where we're at with internationally and in Canada and in Alberta, particularly regarding numbers of cases of COVID-19 in children. And so this first slide shows the dashboard from the Public Health Agency of Canada website, updated a couple of days ago, and gives overall numbers across this busy website. But the upper left corner is a graph that shows cases by age and sex. And not all cases have that information rolled up to the Public Health Agency website. But of the cases that have been, you can see that in the column on the left, there are 4% overall of cases that have been diagnosed in Canada, have been diagnosed in children and adolescents from 0 to 19 years of age. Now, of course, pediatrics typically ends at age 17 years, 364 days, but for the purposes of reporting, reporting includes up to 19. And so most of the data I'll talk about is 0 to 19 years of age. This percentage compares to global data where from a series of COVID-19 cases that have been reported have been anywhere from 1 to 5% that have been children from studies across the globe. So the Canadian number of 4% is quite typical. However, in Alberta, it's quite a bit different. And it's different because there's, while children up to the age of 19 make up the smallest proportion of all cases of COVID-19, there's been a lot more that have been reported. And so this busy double figure comes from the really nice Alberta website that is updated daily. And this is from a couple of days ago. And in the orange bars on the left side, it shows the count of cases by age group. And along the x-axis, there's the age groups. And in the box there, it's under a year, 1 to 4 years, 5 to 9, and 10 to 19 years total cases. And then in the yellow or goldenrod bars, there's the rate per 100,000 per year. And so what you can see by looking at the cases in the orange and in the column on the left, 924 out of 6,901 cases in Alberta, that's 13%, are in this age group. So much higher than in any other jurisdictions that have been reporting numbers. If you look at the rate of disease in cases per 100,000 is still lower in children up to 19 and ticks up a bit in the 10 to 19-year-olds, but still lower than the middle years and upper years of life. So, but a lot more cases in Alberta. And I think, and I'll say it repeatedly, that I think this is related to our testing program in Alberta, which is very extensive and much more extensive than almost any jurisdiction in the world, certainly more than any other province in Canada. Quebec is close, but much more than most other provinces. We do a lot of testing and a lot of contact tracing. And the majority of children who have been diagnosed have had minimally symptomatic disease or mild disease and have been identified through contact tracing more so than through presentation to hospital or any kind of medical services. So if you look in Alberta, persons up to the age of 19 make up about 25% of the population. So certainly they're not tested as often as older persons. About 11% of all the tests that have been done on people under 19 years of age and under. Interestingly, because one thing I'll talk about later is how likely are you to find it when you do testing. So testing being done in the context of there's a reason for it, they're symptomatic or been exposed. About almost 4% of the tests on children are positive compared to 3% of the tests in all other ages. So children, when you look for it, are found just as often as adults in Alberta. Definitely children have milder illness, less frequent severe illness and milder illness overall. In the next few slides will be more about that. So this is also from the Alberta website, and this is a complicated slide showing age groups up the vertical axis and different kinds of healthcare interactions. Hospitalizations with the purple dots, ICU admissions with the blue dots in the middle, and deaths with green dots on the right. And so the key thing from here is there's only been 8 hospitalizations of children under the age of, persons under the age of 20, and no deaths under the age of 20, and just a couple of ICU admissions. So while a lot of admissions, very few have been admitted to hospitals so far. Just briefly with this slide, look at the epidemiologic definition of confirmed versus probable cases of COVID-19 in Alberta. And this is pretty similar everywhere. A confirmed case is somebody who has symptoms and who has a positive test. And that positive test is the nucleic amplification test, or PCR, taken from a nasopharyngeal sample up the nose, or some other kind of respiratory sample. And if you have that, you have a positive case, regardless of whether symptoms you have. A probable case is when you have clinical illness and you are epidemiologically linked to a lab-confirmed case. And so this would be typically a household contact. And this is important when you look at the numbers a bit, as I'll show in the next slide. In these 2 pie charts here, this is data you can download yourself in an Excel file and add it up from the Alberta website. But looking at confirmed versus probable cases. And so in the pie on the left, pie chart on the left, this is under 20 years of age, 924 cases as we discussed before. As I mentioned before, 79% of those are confirmed cases with a positive PCR test, and 21% are probable with a contact but not a test. In most of those cases, the test was not done because of the probable diagnosis being made through contact tracing. This compares with adults over 20, where 91% of the cases are confirmed and just 9% are probable. So that's a distinction to be aware of. So now on to clinical features. There's been quite a few studies that have come out to describe clinical features, but not that many that have been systematic. And so I'm just going to highlight a little bit of the information from the systematic studies. And this was this is data that comes from studies largely from China and from the US. And it's a summary, and I've put in the references at the bottom, and I'm happy, I know this will be posted, and I can send the slides to anybody who's interested as well, or we can post that as well. So most typically through hospital case series or surveillance system, the usual symptom complexes that you see in children are either asymptomatic, no symptoms at all, an upper respiratory tract infection, a URTI, or pneumonia. Those are the most common scenarios by far. And the symptoms associated with those include the things you would expect: fever, cough, shortness of breath, sore throat, headache, sore muscles, vomiting, and diarrhea. There's various laboratory findings that have been seen, and I'm not going to go over that in too much detail, but there is some laboratory findings suggestive of an inflammatory process. And that inflammatory process has been recognized for some time, and certainly in adults, the severe disease that adults get and adults who die often have a very severe inflammatory process in addition to the severe lung disease that they have. So the clinical course is asymptomatic, mild, or moderate in 90% or more of children from different series. Hospitalization and intensive care admission is rare, is uncommon overall. Intensive care admission is rare, and death is very rare. It seems that hospitalization and having to go to an ICU is somewhat more common in infants and young children in the first years of life. And there are some underlying comorbidities, such as asthma, underlying cardiac disease, immunosuppression, that have been associated with hospitalization more than non-hospitalized patients, but that hasn't been uniform. And so, but as expected, some comorbidities are important. And again, mortality is rare. So more recently, people have heard about these hyperinflammatory disorders, and just yesterday, Dr. Dina Hinshaw, the Chief Medical Officer of Health in Alberta, discussed this in her daily briefing because of the news that came out that there's been at least one child in Alberta. And I can tell you from personal experience being on service last week, there's been more than one, but not a gigantic number of children who have had this inflammatory disease. So what is this? I'll just be very brief about this. This is a very wordy slide that is a summary of information from the WHO site on multisystem inflammatory syndrome in children and adolescents temporarily related to COVID-19, or MIS-C. This is based on recent reports from Europe, the UK especially, and North America, where there's been clusters of children and adolescents requiring admissions to PICUs, that's pediatric intensive care units, with a multisystem inflammatory condition that sort of looks like something called Kawasaki disease or toxic shock syndrome. Now, it's important to say that there are many known or suspected infectious triggers for Kawasaki disease. And if COVID-19 is actually determined to be a trigger, it will be just another in a long list of viruses and bacteria that have been associated with triggering Kawasaki disease. And toxic shock syndrome can be a very specific thing caused by some bacteria, and then a more non-specific caused by a variety of triggers. So this hyperinflammatory syndrome was first reported from the UK of a cluster of children in London that had multi-organ failure and shock. And the treatment that has been provided for these children includes the kind of thing we would use for a toxic shock or Kawasaki disease, including anti-inflammatory treatment and some immunoglobulin treatment plus or minus steroids. So this is the WHO case definition, and I won't belabor it too long, but it's this first part looks a lot like what we would see as the clinical features for Kawasaki disease. So children who have fever for at least 3 days, a rash, and then a funny thing where you get red eyes, non-purulent conjunctivitis, and then you may get some changes in your mouth and skin where there's a rash around the lips and some peeling of the lips and swelling and redness in the hands and feet, which is kind of characteristic for these disorders. They may have low blood pressure or shock, and they may have evidence of cardiac disease, and then a variety of blood disorders. A characteristic thing, and certainly in cases that have been seen around here, is that there's preceding gastrointestinal symptoms with diarrhea and vomiting or abdominal pain. That's not so much a part of regular COVID symptoms, although it is in some, but not in most cases, but it's been a characteristic thing here. And then there's the markers of inflammation in the blood and no other obvious cause, and evidence of either having had COVID-19 or contact with it. Importantly here, it seems that this inflammatory disease is a post-infectious phenomenon that comes some weeks after they might have been exposed to or possibly diagnosed with COVID-19. More to come on all this, and happy to discuss it in the question and answer, but I just wanted to mention it for today. So next, I'll spend the last few minutes, and unfortunately I'll be very quick, just going through talking about transmission, because what is the role of children in the chain of infection of SARS-CoV-2 infections leading to COVID-19? And most people listening to this presentation will be aware of the concept of the chain of infection for any infectious disease, starting at presented sort of linearly here, but susceptible host, infectious agent, a reservoir, portal of exit, mode of transmission, and portal of entry. So the question is, what is the role of children? And in particular, I'm going to talk about children as a susceptible host and children as a reservoir in transmission. And there's just not time to go into it in much more detail. So I have a handful of very dense slides to show, and then I'll be finished. So when it comes to how likely are children to be infected? Oops, I think, oh yeah, no, okay. I think my slides are got a bit out of order here. I'm going to go to this slide first, because this is transmission from children to others. Because one of the first pieces of information that came up was that it seemed that children were just as likely to transmit infection to others from household studies that were conducted first in China. And so in this table that shows in the top row data from China that showed, and across there's the source, there's looking at household contact tracing, index cases here, contacts, and then the attack rate in children, attack rate in adults, and then the odds ratio there. So it seemed like from early data that the attack rate in children, 7.3% versus 8%, was about the same. And that was some of the first information that suggested that children are just as likely to be secondarily infected from a primary infection as adults. However, in at least 4 subsequent studies here from China and Japan, and there's not time to go through the numbers in detail, but the attack rate in children who are household contacts or domestic contacts of cases, it seems is lower, with odds ratios ranging from about 0.16 to 0.34. So it seems that in children that attack rate is lower as it's playing out. So that's one thing that may be an emerging piece of information that we have to sort of keep in mind. I'll go back now to say, how likely are children to be infected from various screening surveys? And there's 3 to talk about here. The first one from the, many people have probably heard of the town of Vo in northern Italy, near the epicenter of disease in Italy, where the entire town of about 3,300 people, most of them were tested in 2 surveys in February and March, before and after measures to reduce social contact. And in this study, in the first survey, a small percentage of people were positive, 2.6%, and 1.2% in the second survey after the measures were taken, and about less than half were symptomatic. The point of this is that there were no children under the age of 10 that were positive in either survey of the big population. And then in the 11 to 20-year-old age group, 1.2 and 1% were positive, which was closer but still lower than what it was in the overall population. So this was some evidence to think that children may not be as likely to be infected if you're just looking at the population. In Iceland, a study that was published in New England Journal looked at all ages, but particularly if you look at under 10, not under 20 here, in targeted screening of a population with symptoms or contacts, similar to what we've done in Alberta, what they found there is that overall, of those who were tested, just 7% of children were test positive, compared with 14% of adults. That's quite different than Alberta, where in a similar kind of thing with targeted screening, but with more forceful contact tracing, we've had overall almost 4% of children that were tested were positive, compared to 3% in adults, but identical. And then in open population screening, they found no children were positive, compared to about 1% of the population, so something there. And then very recently from Holland, in an ongoing study that is going to be looking at antibodies in the bloodstream, in the serum, the finding that about 2% of children under the age of 20 have been positive, compared with 4% of adults over the age of 20, so some more hint there. Okay, and so then some other issues that I just will mention to say I'm not going to talk about is how contagious are children compared with adults. Not known. If a child is infected, how likely are they to pass it on to somebody else? And then what about schools? There just wasn't time in the short time to talk about schools. There is emerging evidence that maybe in schools, children are not all that likely, if they're infected, to transmit. However, most of the data that we know from schools comes from studies that were conducted during a time when school attendance was slowing down or stopped. And so there's a real confounder there. So in conclusion, children become ill with COVID-19 disease less often than adults. Most illness that occurs is mild, but they may have severe disease and may have these unusual multi-inflammatory disease syndromes. The higher detection of COVID-19 in children in Alberta is likely related to the vigorous testing and contact tracing practices that have been quite unique here. And the role of children in the chain of transmission in the chain of infection of SARS-CoV-2 appears to be less prominent than for adults, based on limited data so far. So those are the end of my comments, and thank you for your attention. I'm pleased to turn it over to Dr. Exner-Cortens now. So I'll stop sharing here.
Great, thank you. I'll share my screen. Great, so that was an awesome overview from Dr. Kellner on the physical health impacts of COVID-19. And so now I'm going to talk about some of the mental health impacts that we know about, as well as recommendations for caregivers. And like with the evidence Jim was sharing, this is really emergent and changes all the time, but it's the snapshot of what we have right now. So I just wanted to start by what I meant by mental health. I think when we think of this word, people think of lots of different things. And for understanding the mental health impacts on children and youth, I think it's important that we're working from the same definitions. So some people, when they think about mental health, think about mental illness, so things like depression or post-traumatic stress disorder. And that's certainly part of mental health. And mental illness can, in any given individual at any given time, be experienced in low levels or more severe levels. So we think of it along a continuum. Some people, when they think about mental health, think about mental well-being. So maybe how happy I feel, how well I think I'm doing, and that's certainly also a part of mental health. And just like with mental illness, we think about that as along a continuum. So on any given day, for any given person, you know, we might have really great mental well-being or not be doing so well. And certainly, I'm sure for all of us during this pandemic, we've been fluctuating along this continuum, and that's very normal. So when we think about mental health as an entire construct, we think about both of these things. So both presence or absence or level of severity of mental illness, as well as mental well-being. And what's important about this is that even if someone has a mental illness, they can still have optimal mental well-being. And so together then, this is what I'm thinking about when I'm thinking about mental health. And I mentioned anyone can be anywhere in these quadrants. You could have low mental illness and minimum mental well-being, optimal mental well-being, and low mental illness. And so that's what we mean when we talk about mental health. And today, my focus is really going to be on mental well-being, the mental well-being portion of that continuum. So we know, and emerging evidence from China is demonstrating that certainly for people who have an existing mental illness, the pandemic can compound that. But I want to think a bit more generally about what does the pandemic mean for children and youth universally in terms of their mental well-being. So that's what I'm going to talk about today. When we think about mental well-being, I'm going to use this three-part model that's pretty common. And so in this model, mental well-being consists of emotional well-being, so how happy I feel, how satisfied with life, how interested in life. And so I'm sure we can think of lots of ways that emotional well-being has been impacted by the pandemic. We can think about psychological well-being. So this includes if I feel that I have a sense of purpose, if I'm setting out and accomplishing the things that I want to accomplish. And then finally, social well-being. So how socially connected I feel, how well I feel I'm being treated by society, which is important to think about for groups of children and youth, and if I feel that I'm making a contribution. And so that's what I'm talking about, the impacts today. That's what I'm talking about in terms of mental well-being. And so what about COVID-19? So I think it's probably fairly easy to think about ways that COVID-19 could impact all of these pieces of mental well-being for ourselves as well as for children and youth. So we may feel less satisfied with our life if we're not going to school anymore or doing our job, or our job has been changed. And so that might impact our emotional well-being. We might be feeling that we don't really have a purpose right now. Again, if we're not in school or doing the typical kinds of things that give us a sense of purpose. And so that could affect our psychological well-being. And we're probably not feeling very socially connected. And so that could impact our social well-being. And so what might this look like in children and youth as our mental well-being is affected? So common reactions do vary by age and developmental level, but a study out of China with 300 children and youth from ages 5 to 18 found that common reactions were distraction and irritability, clinginess, fear of asking questions about the epidemic. So for younger children and youth, maybe preschool age, we would expect to see an increased clinginess potentially, emergence or reoccurrence of fears, as well as perhaps some behavioral issues and irritability and disobedience. For school-age children and youth, we might see increased separation anxiety, as well as an increased sense of worry. And then for adolescents, potentially a sense of isolation, as well as decreased motivation. And so one of the important takeaways for me today is saying that these are normal reactions to a very abnormal situation. So having these outcomes doesn't mean there's necessarily an underlying long-lasting problem. As children and youth's mental well-being is impacted by the pandemic, we would expect to see some of these outcomes. And so we want to normalize and not pathologize what children and youth are feeling. That being said, from other disaster contexts, we know that 5 to 15% of children and youth will go on to have potentially long-lasting mental health impacts, and that may be exacerbated by an underlying mental illness. And so we want to normalize, but also, be aware if some of these outcomes seem to be really intense or lasting a really long time, and seek help when needed. So in terms of COVID-19 related disruptions, mental well-being is supported by social settings that we're in. And of course, 2 of those settings and others, but 2 I'm going to talk about today, have been majorly disrupted by the COVID-19 pandemic. So our school context for children and youth, as well as the home context. So given the school closure, what are some potential impacts of school closures that have relevance for children and youth mental well-being? So in March, the World Health Organization estimated that about 90% of children were not in school, which is very unusual. And in Alberta, we know schools won't resume till the fall at the earliest. And so this, of course, has impacts on academics, but schools are also a really critical health promotion setting. And so we want to also think about impacts on health. So one of the impacts of school closures that we've been seeing more and more data emerging on is food security. So lots of children and youth depend on the school for a majority of their food intake. So in Calgary, Calgary's Brown Bagging for Kids feeds 5,000 kids a day, every school day. And so not having access to that food through school is really problematic. And then that could be compounded if the family is also facing economic stresses because of the loss of a job. Mental health services, a lot of children and youth also receive mental health services through their school, through a guidance counselor, school social worker, or school psychologist, and may not be able to afford or access community mental health services. Healthy movement also has implications for our mental well-being. For children and youth, it's recommended they get 60 minutes a day of moderate to vigorous physical activity. And without being at school and walking to school or walking around at school or playing at school, there's a lot of concern about children not getting enough healthy movement in a day, and then in turn what that means for their sleep quality. And then finally, social connection. Social connection is really, really critical to mental well-being. And without being at school every day, children and youth are experiencing social isolation. And then at home, where they're now spending most of their time, there's also many potential impacts of the pandemic, but these are some of the ones that are emerging most strongly in the literature. So family stress. Families, of course, are feeling very uncertain about the future, especially if there's been a job loss, a loss of a family member. And so this environment of stress can have negative impacts on children's mental well-being. Beyond stress, we also worry about increases to family violence. So again, emerging data from Hubei province in China suggests that rates of family violence tripled during the isolation phase of the pandemic. And so we worry about the safety of children and youth in terms of both witnessing family violence and directly experiencing child abuse and neglect. Home is not a safe place for everybody. And so we think about children and youth who may face exclusion at home, youth who identify on the LGBTQ2S+ spectrum, and what being at home all the time might mean for them. And then finally, changes to routines because of all the upheaval in home life. So eating schedules, sleep schedules, activity schedules have been very heavily disrupted by the pandemic. And all of these have implications for mental well-being. So what can we do knowing these disruptions have happened? And at this point, there's not that much we can do to the disruption. What can we do in the midst of that to promote mental well-being for children and youth? So my first message is to maintain social connection. Connection is critical for our health and well-being, and so finding ways to do that, both with friends and with school, if that's an opportunity, so that children and youth can continue to maintain that contact. Providing developmentally appropriate information, and I'm going to talk a little bit about that on my next slide. Providing structures and routines. So one of the reasons that all of this disruption affects us so much is it all feels very uncertain, like we don't have a sense of control, and that's really detrimental for mental well-being. And so we want to bring back those structures and routines. So sleep times, eating times, taking scheduled breaks, having activity times. it's really important for the well-being of children and youth to implement those structures and routines, while understanding it does put another burden on caregivers to do that while they are also probably trying to work their own job. As part of providing structures and routines, encouraging healthy movement, whether that's on or offline, using that as an opportunity to spend time together. Taking care of yourself as a caregiver is really critical. Children and youth take cues from their environment about how to process what's going on, and a big cue in the home is caregivers. And so it's really important that you're taking care of yourself as well. And then, as I talked about at the beginning, knowing when to seek help. So most of these reactions are normal reactions to an abnormal situation. But if it's really severe or going on for a long time, knowing when it's time to reach out for help. So how do we provide developmentally appropriate information? This idea of having realistically reassuring conversations comes from the American Academy of Pediatrics, and I really like it as a term. So what they mean by that is having positive conversations that are also honest. So not trying to sugarcoat things, and of course that depends on your child's developmental understanding, but being honest, positive, and open, helping children to sort out myths from reality, and really providing a space to have emotion-focused conversations. So yes, talking about facts, but also giving that space for children and youth to talk about how they're feeling, normalizing those reactions, sharing, especially with adolescents, how you yourself are feeling in the situation, letting them know they're not alone is really critical. So to have those emotion-focused conversations, you might want to find different ways to help children and youth express how they're feeling. So adolescents are very much able to talk at a high level in an abstract way, but for younger children, you may want to do that through play or using puppets. And for all ages, art is a great way to express emotion. For younger children who are still developing an understanding of cause and effect, it's really critical to communicate with them about how COVID-19 has spread, that it's not because they did something bad or anything that's their fault. So trying to talk about the facts around COVID-19. For slightly older children, ages 7 to 12, they're pretty good with cause and effect, but are still very logical thinkers. And so thinking about, focusing conversations on what they could do or their friends could do, and not broader global understandings is important. And then for adolescents, really talking with them and asking them how they can be a positive peer influencer among their friends. So peer influence is huge in adolescence, and so we want to encourage adolescents to be a positive social influencer. So how could they maybe make an Instagram story about social distancing or wearing a mask? Adolescents do have trouble thinking into the future and are more risk prone, but they also have a really great sense of justice and fairness. And so we want to draw on the strengths of adolescents during this time by actively engaging them in their response. So here are some websites that might be of interest to you. So this one is the COVID-19 Health Literacy Project. And again, these slides will be posted. And so they have tip sheets for ages 3 to 6, 6 to 12, and 12 to 18. And they're available, I think, in over 30 languages. Another website, COVID-19parenting.com. This website collates information from the World Health Organization, UNICEF, the Centers for Disease Control, and a number of others, with resources available in over 35 languages. So what about screen time? I think this is a big concern among caregivers right now. And I think the best response I could give is that it's really about balance. So we know that excessive screen time can have detrimental impacts for children and youth. We also know that screen time can be positive in terms of playing video games and developing motor skills and cognitive skills. And we also know that a lot of families right now are just trying to get through the day. And so I think first and foremost, it's important to be gentle with yourself and know that you are doing the best you can in this very strange time. But there are some guidelines about how to work with the fact that children and youth are going to be using increased screen time because now it's not only a pleasure activity, but also potentially how they're accessing schoolwork as well as connecting with friends. So taking breaks, and this isn't just for children and youth, this is important for all of us. We're all spending a lot more time on the computer and on screens than we may have been before. And so taking scheduled breaks in your day away from the screen is really important for everyone. making a plan and setting boundaries. So talking to children and youth, and again, depending on their age, this would look a little different, but how much time are they going to spend today? You know, when can they log on? When can they log off? When do they need to take a break? So putting that again into that routine and structure that we talked about. Keep communication going. So COVID-19 information is stressful for all of us, but can be especially stressful for children and youth. And so talking about what they're seeing, for younger children, this can mean just restricting access to certain sites. For adolescents, where that's less possible, talking to them about what they're seeing, talking to them about limiting the amount of time they're spending reading about COVID-19, and again, having those emotion-focused conversations. Using screens to do activities together. Screens are a great way for you to spend time with children and youth, so playing video games with them, doing an educational activity, watching a movie. So finding a way to use screens to facilitate social connection, either with you or with their friends. Again, back to healthy movement, making sure kids are getting physical activity, which can happen online. So playing, certain Wii Fit games or other types of online games, but also getting offline and getting some healthy movement. And then depending on your situation, what's possible, scheduling face-to-face family activities if and when you can. But again, understanding that you're probably working what feels like 2 or 3 jobs right now. So just doing the best you can within these recommendations. And finally, I just wanted to say that we know that all children and youth need support. So COVID-19 is stressful. It can be especially stressful for children and youth who are still developing cognitively, which impacts how they understand the situation, who might still be developing coping strategies, whose entire worlds have been thrown upside down if they're not in school. And so we want to support all children and youth. But certain children and youth need a little bit additional support. So children and youth with special education needs, children and youth, as we talked about, who identify on the LGBTQ2S+ spectrum, children and youth experiencing racism. So we want to think about children and youth in our lives who might need that additional support. An analogy I've heard on social media that I really like is that we're all in the same storm, but we have different boats. And so thinking about how we can provide that extra support to children and youth who might need it. And then lastly, looking ahead, and I think this ties nicely into what Dr. Kellner was saying. So evidence is emerging at a wildly rapid pace, and we're constantly changing. And as I talked about, one of the reasons this can feel so stressful is that everything feels uncertain, which is made worse by the fact that it seems like guidelines are constantly changing. And so it's a good thing. We need to continue updating what we're doing based on the most current evidence about how we can support children and youth. But because that's stressful, I think it's important to talk to children and youth about the fact that information is going to keep changing, and that's because we're trying to do the best we can at a given moment based on what we know, and then we might need to change that when we learn a little bit more, and that's okay, and that's actually a really good thing. So just as one example, this is from a systematic review in The Lancet that came out in April, which concluded that actually closing schools may have a relatively small effect due to some of what Dr. Kellner was talking about, and also, as we've talked about, has profound economic consequences. And so this is new evidence that came out after a lot of the school closures happened, and it's still an emerging body of evidence. So in 2 months, this conclusion might change. And we just need to keep balancing what we know with what we're learning and communicating that the changes that we're experiencing are a good thing and that we're doing the best we can in a very uncertain time. So I will leave it there. I have some, all the things I cited in further reading and references. So when the slides are posted, you're able to access that if you want to.
Thank you very much for both of your presentations, which were excellent. So we will now open it up to questions from our audience. I think I will start with Dr. Kellner. We did have a question which you have answered already quite nicely in the Q&A, but I think it might be interesting for us both, all three of us, to engage in this discussion about what our perspective is here locally regarding opening up playgrounds, daycare, schools, during phase 2, and what the risk, knowing that is, especially since younger children cannot understand what a 2-meter distancing is and how to keep on a mask. So maybe Jim, if you wouldn't mind starting, and then Deinera, you can also chime in.
Sure. Thanks, Christine. I think It's a tough question. I think one of the things that comes up with this question, though, is this idea that as we move forward, the societal focus needs to be in a collective way, in a thoughtful way, in a way where people interact and discuss these on the minimization and mitigation of risk, but not elimination of risk. We can't go forward and think that we can eliminate risk. At the beginning of all this, there was this, I think, a strongly held view that the aim was to eliminate risk because we just didn't know how bad it was going to be. It's been pretty bad some places like northern Italy and Wuhan and New York, and many other places it's been less bad, but you didn't know how it was going to be. So going forward, as we have done all these things to mitigate risk and slow down disease, and we've been amazingly successful here in Alberta, how do we loosen off in a way that will be safe, but still acknowledge that there's going to be, as people have put it, this slow burn of infections going on in the background, hopefully not that many people get sick. So with that preamble, sorry, I think a way going forward is you still can do what you, as things open up, and you can still do what you can to make it as low risk as possible. And so there are these principles that have been enumerated to say you shouldn't open up until you have a low rate of disease in the community, as we do now, and a lower and lower rate. And it's been more in Calgary than elsewhere, but we have a lower and lower rate. We have good capacity in our system to test and do contact tracing. We have good capacity in our system to care for sick people. And we have enough equipment and supplies in our system. So then how do you open up and how do you allow kids to get together? I think some of the principles that we discuss is, okay, you have to make sure that there's good screening in place. And so that on a daily basis, you make sure you're screening, and you really are quite strict about excluding children who are sick from coming to school or daycare on that day. Probably more strict than we're used to being on that. There has to be limitation in the size and number of interactions. So perhaps smaller class sizes, and this is being looked at all ages. And certainly reducing gatherings, so you don't have large, assemblies in schools. And probably some shorter school days where kids are not in school as much time, so there's not as much interaction between them. Making sure you limit, even if we're thinking that children may be less important in the chain of infection, limiting the interactions of children with adults who may be at particular risk, older teachers or bus drivers or school staff and the like, not having to have so much direct contact with children. And then we're going to have to accept that children will be contacting each other, and young children especially won't wear masks, they won't stay close together, and accept there'll be some risk there, but hopefully having minimized the risk. There's more to say, but I'll stop there.
Yeah, I would just agree. The move to what I think of as a harm reduction approach as opposed to a risk elimination approach. So I think it is changing our thinking as we have learned more and where we need to go. And then, yeah, it's going to be really hard with younger children, but I think as they get back into school, thinking about teaching distancing and mask wearing like we think about teaching lining up and staying in our desks, so we can use those same behavioral principles with younger children, and then with adolescents, again, engaging them and thinking globally and why their actions matter at a global level, how it's part of justice, and then how they can be a positive social influencer.
Jim, did you have any supplementary things on that topic that you wanted to add? It sounded like you stopped yourself from saying.
No, I just don't want to be talking. What I did respond to is the question about playgrounds. And so playgrounds are tougher. I think all the same kind of principles apply as we've talked. Don't bring your child if they're sick. Make sure it's not too crowded. I think the thing of, and then this will be a thing where for now, if you're in a setting outside, we haven't talked about masks at all, but if you're in a setting outside, certainly the adults, if they're not going to be able to keep social distance, should be wearing masks. And then the question of what's feasible in terms of parents and caregivers actually cleaning playground equipment. It's an easy thing to say, but I think it's much more difficult to actually sort of accomplish that. So I think the main thing is to, if there's already right by my house, there's a small swing and slide that can accommodate, 4 or 5 children. And if those 4 or 5 children are already there, or if there's 1 or 2 children already there, maybe come back at a different time and try to minimize the contacts that are there.
Just one quick supplementary on that topic. I know that in our task force, we talked about school buses. Did you want to add anything about the school bus topic?
Right. So school buses, so two things to say about school buses, for sure. One is, again, the risk to the drivers. And, it's a pretty common thing that school bus drivers are often retired from doing something else and sort of older community members. And so it's an important thing. And I know that there's been, sort of plastic screens put up and that we have to pay attention to that. With Calgary Transit putting in rules around entering buses from the rear or the side doors to minimize contact with the driver, that's a thing to do. But I think the most practical thing is reducing capacity on the buses. And so how feasible this is going to be, because if a bus is full, eventually taking a group of kids to school, and we say it can only be half full, how are the other half of those children going to get to school? Is it because they're not coming every day? That has to be planned for, or their parents are expected to bring them. That has to be planned for. So just to state, okay, well, the school buses will only be half full is completely impractical unless there's a plan in place of how you're going to accommodate that, with either taking turns going to class or making formal arrangements for somebody else. But I think, avoiding the jam-packed school buses is going to be important here for a while.
For sure. Okay, so we'll go on to our next question. This is from Jennifer Sloveninsky. She's asking, are there any data pertaining to children with a history of Kawasaki contracting COVID-19 and experiencing MIC?
So Kawasaki is a rare condition, and it's about 1 in 10,000 or more a year. And so there just simply haven't been enough cases to say, have the overlap of having had a history of having had Kawasaki and now getting COVID and see what that looks like. It's a really good question, just especially in terms of the whole thing of the concerns around, do we make effective antibodies or not with natural disease? So, but there's no evidence that I've seen on that yet, and I expect it'll be a while till we see evidence on that.
Okay, thank you. Next question from Mandy Dale is, I'm wondering what the chances are that schools will be able to reduce class sizes in light of the recent budget cuts. Is the scientific community being asked to advise on this topic? Will government support the recommended course of action? A lot of big questions that we may not answer, but do you want to, who would like to take that one? Maybe both of you could.
Yeah, sure. Yeah.
I would just say, yes, I think it's a really good point. And we know, like, the Calgary Board of Education has already talked about that they're actually going to have to up class sizes in the fall. And so it's a great point. And I don't know, maybe Jim can talk about, as a COVID-19 task force member, about being asked to advise. I would hope they would seek that out. And certainly as individual citizens, I think it's something great to write to your elected officials about, and why large class sizes are a concern regardless in terms of children's developmental well-being, but especially in this time of COVID-19, that it's a real risk to children being able to go back to school, which we know are so critical for their social and mental well-being. And so we don't want to have another reason that they can't go back to the classroom. That's all I would say.
Yeah, excellent.
I'll just add, in post-secondary education at the University of Calgary and other universities and colleges, the planning is going ahead for the concept, and across the country, the plan is going ahead with the concept of having reduced class time. So some online and some in person. And then the idea, and there's actually, of course, there's modeling on, but math modeling on this is, if in a university setting, if you keep students within their smaller unit within a school or a stream or a theme in that, and avoid the large 1,000 student classes that there are, and have those ones online, and then try to keep students sort of a little bit apart and fewer classes. That's probably more amenable in a post-secondary setting where young folks have already come through the whole primary and secondary school setting and can probably handle that a bit better. In the primary schools and what's happened with return to school so far, like in Quebec and even some places in the US where kids have gone back to school, it's been alternating classes. So reduce class sizes through reducing the number of days a week that children go to school. So, A to L go to school on Monday, Tuesday, and Thursday afternoon, and M to Z go other days. How practical and how feasible and how doable that is remains to be seen. So, but that's a practical, politics aside and social evolution aside, that's trying to be practical about reducing the class size that way. Harder to achieve, I think, in primary schools especially.
I think maybe I might just chime in with our COVID-19 task force. I mean, we have actually been looking at what kind of policies have been implemented internationally on this topic. And we're really trying to learn from the experiences, particularly in some of the European countries that are a bit ahead of us as far as the pandemic is concerned. And that will help inform some of the policies that are being implemented locally, but also provincially. So yes, we'll go on to the next question. This is another one for you, Jim, from Albie Sol. He's wondering, he said, that you mentioned that the MISC tends to show up later, suggesting that the COVID safety plans being developed for day camps need to include direction for parents to be alert to these symptoms after the camp has ended so they can seek help early. He hasn't seen any of those kinds of guidelines being developed, and so we're just wondering what your opinion is on that topic.
Yes, so thanks for that question. Definitely right now we think of COVID in sort of the time-limited period of up to 2 weeks period of incubation, and that if you haven't developed symptoms by a certain time, you're probably not going to. That's in the setting where you might know you've had a contact. I think what it comes down to for these post-infectious, especially the MISC, which is going to be, especially at the worst end of it, quite a dramatic illness. It's what you would recommend in terms of common sense recommendations to parents anyway. If your child has a fever that persists, is unwell in a way that is uncommon for them, has a bad gastrointestinal illness, more vomiting and diarrhea, it's really the severity and persistence of symptoms, especially this persistence of fever and the severity of other symptoms. This won't be, as it declares itself, that mild of an illness. It'll be quite notable, so in regular times, you would not take your child to school or outside if they had those kind of symptoms, most people. And so I think it's framing it as saying that could happen as a later phenomenon for sure, but it's your child's going to be unwell in a way that you should be concerned about, regardless of whether it's COVID time or not.
Right. Oh, wait, looks like we've got another question that's just come up. So Mandy Dale says, another question from Deinera about mental well-being. Her daughter seems to be tired all the time since school was ended. What can she do to help her?
That's a great question. And I'll just speak a bit generally, not knowing your daughter or what age she is. I think, depending on the age, if you're able to talk about why she's feeling that way and getting a sense, obviously, as I was saying, we want to normalize a lot of the emotion, but also want to make sure there's not something more serious going on. And so having those conversations in a way that's developmentally appropriate. And then again, depending on the age, for if she's older, maybe talking about with her, like what would help with that. For younger children, trying to set a routine, getting that back in place if it's not in place. So it's hard to say specifically, but I think it's great that you're noticing that and then just trying to talk to her about, what might be going on and then problem solving from there. And noting that there's lots of mental health support right now. So you could call the Distress Center or Calgary Counseling. They do online or telehealth, telepsychology. Some school divisions are doing that as well. So if you're worried that there's something more serious or persistent happening.
Yes, she's just provided the additional information that she's not and sleeping about the same time as before. Yeah. So at 9, I think you would be able to talk with her about that and get a sense of what she feels might be going on. And it might just be, tired from lack of motivation, not feeling like she has a lot to do or a sense of purpose. So I think then brainstorming from there might be able to support her to feel better during this very strange time. So we have just maybe a minute or so left. Do either of you want to add anything that you didn't have time to say in your presentations that you think are important? Because this is such a rapidly evolving topic and field. Jim or Deinera? Yes. Deinera, do you want to start?
I don't think I have much else to add. I really appreciate that during the discussion, the idea of harm reduction came up. I think that's going to be really critical moving forward. And I think that goes along with what I was saying about the rapidly changing advice, and that can be stressful in and of itself, but it's okay. We're just trying to do the best that we can based on what we know at the moment. And so preparing yourself and your children and youth for the amount of changes that will keep happening, I think is really important.
Yeah, and just to further that, I'll just say I think that we're in this for the long haul. I would suggest at least a couple of years of some big changes in our usual sort of societal patterns and how normal things can be or not. And I just think it's really important with children to strike a balance between not, on the one hand, dismissing children as unimportant in the whole chain of infection and transmission in the community, but on the other hand, not overreact. So this thing of opening up at first, and it's interesting in the last few weeks that, I've been talking to people about opening up, and I would guess at least people who sort of come into the sphere that I speak to have a lot of concerns about opening up, and people are pretty nervous, and that's probably a good thing to be nervous, but we do have to get over the hurdle of fear of opening up in any way, and then just say, how can we do this practically with a harm reduction approach? And I do think it's going to be important to have meaningful discussions about, what does that look like and what kind of risks are we willing to take on. And there's going to be a ton come out on comparison and contrasting how jurisdiction A did it versus jurisdiction B, and what was better or worse. And there will be, in the same way that there's a lot of new COVID and infectious disease experts, there's going to be a lot of experts on how could we have done what we did and how couldn't we have done what we did and all that. And I just think that we need some, humility around this, but a willingness to sort of, move forward now.
Lessons learned. So we had a few questions that came in at the very end that we don't have time to answer, so we will send them to our speakers and have them answer offline. And I just want to remind everyone that we have recorded this session, and so it is available on the O'Brien COVID-19 webpage if you want to share it with someone else or want to see it again. I want to just take this opportunity to thank our two speakers for very excellent and engaging discussions today, and thank our audience for joining us. And I'll end the session now since we've run up against the time. So thanks to you both, and goodbye.
Thank you.
Thanks. Bye-bye.